And there were two approaches right from the beginning. There was the submerged approach of Professor Agronomar, and then Professor Schroeder introduced the one-stage transmucosal, the ITI implant, now the Straumann implant. But essentially, this was the focus in the first 25 years, and the focus was implant survival. Implant survival, how these implants survive over a period of time. The next 25 years, the focus changed because we started to treat more and more partially edentulous patients, short spans, single teeth, and big focus then came on dental aesthetics, single teeth in the maxillary and anterior region. Shorter non-loading healing periods because of the technology with implant surfaces, and of course, a popularity with immediate loading protocols, single teeth, short spans, and full arch immediacy, which we will speak about today. So this has come about because of a very key partnership between the dental industry, a company like Straumann, and between clinicians. On the one hand, we see us in clinical practice, treating our patients, and then we are seeing problems that we want to try and solve. We see clinical indications, soft bone, minimum bone height, narrow ridges, compromised patients. So we are always trying to find solutions for these types of patients. And then the dental industry tries to respond to this by being innovative in their technical developments to try and give us as clinicians the solutions to some of the problems that we are trying to treat our patients. And over the last 50 years, this has been a success story. This has been very, very successful because now dental implantology is mainstream dentistry. It is no longer, a niche. It is no longer just a small group of individuals providing the treatment. It is widespread throughout the dental community in the whole world. If you are not practicing at least some aspects of dental implantology in your practice, then you are no longer providing your patients with the best possible care when it comes to rehabilitating the dentition. We must at least talk to them about it. So with Straumann, the technological advances have been really very astonishing. In fact, this company has been the leader in the development of not just the implants themselves, the implant materials like rock solid, for example, which is unique, but also technological advances with implant surfaces. And they have partnered with key researchers and clinicians to provide the clinical evidence and the clinical data to support us by giving us strong evidence that these technologies work. And of course, the latest one now today we talk about later this afternoon is the new TLX implant, which provides us with such great advantages when it comes to immediacy. So it's a technological building blocks. Each advance brings on the ability to do the next, and then the next, and then the next. And this is how this evolution of technology has helped us in clinical practice. So as I said, we started off talking about survival of implants. Today, we are much more interested in how successful these implants are, because most implant systems today have high survival rates. If they are moderately rough and they have treated surfaces, then generally speaking, they have quite good long-term survival rates. But we want our implants to be trouble-free, with minimum amounts of complications. So the focus over the last 10 to 15 years has been to look at success and how we can make our treatment successful. And the aim of treatment for our patients is to provide them with a predictable, long-term outcome with minimal risk. So now I ask everybody in the audience, what do you think is long-term? 5 years? 10 years? 20 years? 30 years? What's long-term? In Australia, the average lifespan of the Australian female is 88.5 years, 88.5 years. So now I see a patient 30 years of age and I place an implant. Will that implant last 50 years? You see, the history of dental implantology is actually very short compared to the history of teeth and dentistry understanding caries and periodontal disease and so on. We have a much longer experience with it than with dental implants. So this is where we have to think about what we do every day, because the patients I'm treating today I will not be here in 20 years because I will be retired to look after them. So we have to have in our mindset long-term predictable outcomes. And how long is long? As long as possible. Hopefully for a lifetime of that patient. And by doing this, what we are trying to do is to minimize complications. And why do we want to minimize complications? Well, number one, we want to protect our patients to make sure that they are not harmed in any way by our treatment. But we also want to minimize complications for us. Because if you practice dentistry and you have a lot of complications, then dentistry is no longer fun, it's no longer satisfying, and it's no longer a profitable business to be in. Right? So whichever way you want to look at it, we want to minimize complications, not just for us, but also for our patients. So for today's program, for the whole day, I'll start off by talking about technology in a way, how does it improve our long-term outcome, or how does it give us solutions? This morning I will talk about functional success. After the coffee break, I'll talk about aesthetic success. In the afternoon, I'll talk about strategies for peri-implantitis. And then the last session, we'll talk about the TLX implant and how this new implant can help us with certain clinical indications. Okay, so that's the program for today. So let's look at functional success. This is a patient I treated in 2005. At this time, she was already in her early 60s. Healthy lady, we placed implants, and this is her at her most recent recall 18 years later. Now you notice we have missing tooth. We have now missing molar tooth here. So she developed pain from a fracture and ended up having to take that tooth out. But the two premolar implants are still in place, and you see healthy peri-implant tissues and see the healthy bone support on these tissue level implants over 18 years. I tell you now, I love tissue level implants. For long-term stability, you cannot go better than a tissue level implant, and I'll talk about that later this afternoon. So this is what we want to see, long-term success. She's now in her early 80s and having some issues with, dementia, and she's frail, she's on a walking stick, but she still has teeth to function with. This is another patient I treated in 2005. And if you look at the anterior implant, this one here, this implant here, and you look down 2009, 4 years already recession. And then fast forward 17 years later, the recession is worse, and you can actually see some metal of the rough surface exposed on the implant. And if you look at the corresponding x-rays, nothing, and look at the anterior implant, which is this implant here, the premolar implant. So that's 2005, 2009, 2018, we're already starting to see some cupping effects. Okay, so that's 13 years later. And now we go to 2022. And we can see clearly changes around these implants. And the question we have to ask ourselves is, why is this happening? Clinically healthy. No inflammation, no peri-implantitis, no mucositis. But things change over a long period of time. So all of those of you who have just early in your experience with implants, that means 10 years or less, watch your patients very carefully, document, take photographs, because you will start to see things that are quite unexpected in some individuals. And when we see changes like this, we must ask the question, why is this happening, so that we can try in the future to prevent or at least minimize the risk of these things happening. So these are the complications that can compromise the implant. So bone loss, soft tissue recession, so these things are important for us to look at. Occlusal overload is another area. We lose implants through this, and then peri-implantitis. So I'll talk about peri-implantitis this afternoon. These are the two areas I will focus now on the functional success. So when it comes to the bone, these are the things I think have an effect on marginal bone levels around the implants. Post-extraction resorption, the quality of the soft tissues, the implant design itself, the prosthesis, and the bone itself, the volume of the bone. So if we look at dimensional changes, you'll see from this paper from Straumann that when you take a posterior tooth out and you monitor it for 12 months, you'll see that over a 12-month period, 2/3, almost 50% of the original width is lost in an undisturbed extraction socket. And 2/3 of this happens in the first 3 months. So it's very fast, very fast. And this is because we get this rapid resorption of the facial bone. So if you look at this diagram here, which is data from a number of studies put together, if you look at the vertical resorption of the facial or the buccal bone, you can see that within the first 2 months, already a rapid change, 1.5 millimeters, and then it's quite flat after that. So rapid change and then it slows down. If you look at the horizontal resorption, that continues, straight line. So there's two separate processes that are going on. The first is resorption of the facial bone. The second then is a slow modeling process. And the question is, how long does this modeling process go on? 2, 3, 4, 5, 10 years? We don't know. We don't know how long these changes take place because the studies are very short. Now here's a patient who was referred to me because she had pain from one of the implants, the 2-1, the left central incisor implant. 2 implants, 2-1 and 2-3, both immediate implants. In the end, we opened up a flap to see what was going on. And this is when the prosthesis comes off, and this is now the flap open. Both immediate implants, both grafted with bovine bone mineral. Can you see the changes that took place? On the canine implant, you can see a very thin layer of bone. This is a very fine layer of bone on this implant. If you take a CBCT, you will see no bone, but the bone is there, it's thin. Here, on the other hand, you can see thicker bone, but in the apex, you can see a fenestration. Okay? So this just shows you that even if you graft the site over a period of time, changes still take place. And by the way, this is what was causing the pain. This was bone that had pushed out from the extraction socket when the implant was placed. So it was like that for 4 years, never resolved, giving her pain. I removed that, pain disappeared, problem was solved. Right, so this is quite unusual, but I'll show you this case to demonstrate the dynamics of the bone changes. Now, if you have more missing teeth, multiple extractions, you get much more rapid dimensional change. So the more teeth you take out side by side, the more rapid is the change. Right, this is an animal study, a dog study. Probably only one published that looks at multiple missing teeth like this. So the reason is we know now the bundle bone theory. When you take out a tooth, you know that the bone that surrounds the extraction socket is made up of this specialized bone called bundle bone. And bundle bone is what the periodontal ligament fibers from the tooth insert into it. It is a specialized cortical bone. And according to Moritz Araujo, when you take out this tooth, then the bundle bone no longer connects to the tooth, and therefore it resorbs. And we see this resorptive pattern. And because the bundle bone is thin on the facial or the buccal side, we lose dimension. The bundle bone on the palatal or lingual side is supported by the rest of the alveolar ridge. So the bone is thicker. So even when the bundle bone is resorbed, the bone remains, but on the facial side it resorbs. So this is the bundle bone theory. So here's a case, a very dramatic case. These are lateral maxillary premolar implants. This is 8 weeks after extraction, early implant placement. I placed the implant. And you can see here the shape on the buccal side, straight after the implant goes in. And this is 10 weeks later. Thick bone has undergone modeling changes. It is dramatic what takes place. Now, there's nothing wrong with the implants. Implants were restored. The aesthetics were fine from the buccal side. But I show you this because very often we don't see these occlusal views of the changes that take place. This is Mother Nature driving this modeling process in the bone. So it doesn't matter if you start with very, very thick bone, it can change, in this case, very dramatically over a short period of time. All right, so let's look at the soft tissues now. We know the biologic width around implants is 3 to 4 millimeters. Okay, so you need to have 3 to 4 millimeters to establish attachment of connective tissue, the neck of the implant, the junction epithelium, and the sulcus. Okay, this is well established. But then when we look at an edentulous bridge, the mucosal thickness is roughly 2 millimeters in the mandible, 3 millimeters in the maxilla. This is less than the biologic width. So all of a sudden there is a discrepancy between what an implant needs to maintain integrity and what Mother Nature gives you when you have an edentulous ridge. So of course we now understand that this initial tissue thickness can influence the crestal bone changes around your dental implants. Implants placed with initially thicker peri-implant soft tissue have less radiographic marginal bone level changes in the short term. And this is a most recent systematic review looking at this. So the evidence is very strong. If you have reduced keratinized tissue, so not just the thickness but also the quality of the tissue, then in another systematic review, this increases the risk of peri-implantitis, increases the risk of plaque accumulation, soft tissue inflammation, mucosal recession, and marginal bone loss. Okay, so tissue, quality of the tissue, and the volume of the tissue affects the underlying bone. And then if you, in your prosthodontic procedures, multiple in and out, take the crown on and off, abutment on and off, repeatedly to check, to correct, then the more you take it on and off, the more you break the seal, and the more you end up risking the marginal bone levels. So the recommendation is do the minimal amount when you are doing the prosthodontic phase of treatment. Yeah? Not too many times on and off. The one-time abutment is probably better in the long run. The next thing is the implant itself, and we know this big debate that happened over 15 years about what was causing the marginal bone loss. We had the microgap debate, the gap between the implant and the abutment. We had the platform shift debate, whether the platform was on the implant, inside the implant, and what the taper on the abutment was. We had the debate between external abutment connections, internal abutment connections. So all this happened over about a 15-year period until we understood the requirements to minimize bone levels. So if you look at these radiographs of different implants, external hex tissue level on the left, external hex and bone level, and if you look at where the restorative or the shoulder of the implant is, and you can see the bone levels. Well, clearly the bone level implant is the one that maintains bone. And the characteristics of the bone level implant design is that it does not create a bone saucer. So all those other implant designs create an irritation at the implant abutment interface that creates a low-grade inflammation, and the bone resorbs and creates these saucerization. When the bone is thick, you see a saucer here. So here's the saucer, there. When the bone is thin, there's no saucer, it just resorbs. Okay? So the clinical outcome depends on the initial thickness of the bone. Tissue level implant, there's a bone saucer. External hex implant, bone saucer. Bone level implant, no bone saucer. Okay, so the implant design fundamentally has an effect on the underlying bone. We know this today. And this is a paper that we collaborated on. We did this in Melbourne in 2013. And here it's a mini pig study. And this is the only study I know of that compares different implants designs to see the effects on marginal bone levels. And the summary really is, if you want to minimize crestal bone level marginal bone loss, you must have an internal abutment connection, and it must be conical, less than 45 degrees, which provides that platform switching effect. And it also gives you a very stable implant abutment junction, so the abutment does not move within the shoulder of the implant, and you need an osteoconductive surface like an SLA surface. All right, when you have these requirements, then you can maintain bone around the implant. And you can see from this radiograph here, on this bone level implant, you can have the crest of the bone coronal to the implant abutment interface. I'll talk about that in the lectures after the coffee break, why that's important for aesthetic outcomes. Now, a systematic review has shown clearly that the best bone maintaining designs are an implant with an internal connection of less than 45 degrees, like a Straumann bone level implant, or a tissue level implant, Straumann tissue level implant. These are the two implant designs. Doesn't matter what manufacturer, but the two basic implant designs that will result in the least amount of marginal bone loss. So your choice of an implant will make a difference as to how the bone responds and whether it increases the risk of soft tissue recession and changes over time. So technology, implant design, has a direct impact and a direct influence on the response of the bone and the soft tissues. This is the latest systematic review fact from, I think from the EAO, I think it was, Schoenbaum. Okay, what else in the prosthetic design, the prosthesis? Well, many things can happen which can influence the bone. And there is now some strong evidence that if you have short abutments on your implant, especially in the aesthetic zone, you're more likely to have more bone loss around the neck of the implant than you have a long abutment. And this systematic review, this is not me, this is another Chen, but this is a systematic review that showed some strong evidence that the length and the height of the abutment makes a difference. Basically, anything that's too close to the bone is going to have more effect on the bone. Yeah, I think it makes absolute logic and common sense with this. And what about some of the other prosthodontic factors? So I looked at highest levels of evidence in systematic reviews, just to give you a summary. Now, you know there is some debate now about the emergence angle on an implant. And that here, you can see two implants side by side with different emergence angle. One that's narrow and one that's wider. And there is some evidence to say that if you go wider, you have more bone loss. We have animal studies from the Harvard group with Kemal Galucci showing very nice animal histology to show this. But clinical studies, clinical radiographic studies, unfortunately, doesn't come out significant. So in the most recent systematic review by Atiye and co-workers here, what they showed was that if you have an emergence angle less than 30 or more than 30 degrees, there did not seem to be a difference in the marginal bone levels. Okay? So we still have to watch this space for research, for additional research to give us some information. At the moment, the evidence is not there. And then if you use a ceramic or a metal ceramic prosthesis crown, it makes no difference in the marginal bone levels. Everyone says zirconia is better for soft tissues. Zirconia is better for soft tissues and bone. The evidence is still not there to make that claim. Okay? And what about all the other prosthodontic variables? You know, ridge lap versus no ridge lap for plaque retention. The fitting surface of your prosthesis is convex or it's concave. The manufacturing technique, CAD/CAM, or traditional methods. Whether you use a provisional prosthesis or whether you go straight to the final restoration. Prosthetic fit. All these are lacking evidence. There's no systematic reviews or there are not enough studies to provide enough information. So, for those of you who are still, maybe there are some students in the audience, these are some areas that we really need more research to give us better understanding and more information. But to summarize, what you do restoratively has an impact on the bone levels. Yeah, there's no doubt about that. So if you repeatedly take an abutment and a crown on and off, you're going to damage the attachment eventually. Yeah. If you put a short abutment rather than a long abutment, it's going to have an impact. If you choose an implant that has a saucer effect, then it's going to cause more bone loss. Okay, so these are important factors that remain. Now, I want to switch to another topic which is very, very important, which all of us are doing with our patients, and which is, I think, one of the biggest causes of marginal bone loss. And this is when you place an implant into a narrow ridge. Because you want to save your patient a bone graft, so you try to squeeze an implant in. But then over a period of time, we see bone changes because the implants have gone into a narrow ridge. This is one of my first Straumann bone level implants that I placed 15 years ago. Okay, I was doing this as part of a pre-launch. I learned how to use this implant, using the profile drill and so on. So this is 8 weeks after placement. I can already see some bone loss. What's going on? This is a narrow ridge, and I've squeezed these implants in. And now this is when the implants have been restored. So now I look at this and say, well, what's happened? Well, firstly, the implants are too close together. But that's not the only reason. The implants have gone into a narrow ridge. And you see this particularly in the mandible and in heel sites. Okay, so what is going on? So we know today that this is a phenomenon known as avascular necrosis. Avascular necrosis. The bone is dying because of poor blood supply. It's not infection. It's not periimplantitis, it's avascular necrosis. And when you have a narrow ridge like this, you see that it's well corticalized, especially it's well corticalized. So Professor Boozer provided me with this image. What you see is an implant placed, and the bone is very thin. The bone is very thin in this cortical region. So firstly, the periosteal blood supply is interrupted because you've retracted a flap. So no periosteal blood supply. Secondly, no endosteal blood supply, because now the implant sits there. So from the outside and from the inside. And then of course the only blood supply is through the cortical bone, because there's no trabecular bone coming through it. And we know cortical bone is poorly vascularized. It's only the Haversian system. It's no wonder this bone dies. It's got no chance of surviving. And then what do you do when you put your implants in? Oh, I want 100 Newton centimeters of torque. So you crank the implant in, and it's stressing the cortical bone at the neck of the implant, which is, I'll talk about later with the BLX, TLX implants. Be really careful you do not overstress the bone. Bone should not be stressed to such high torque, because that further compromises the issue. Okay? Now, we now have the definitive animal study to tell us this. This is by Alberto Monche in 2019. And they designed this study in a dog model with different bone thickness after the implants were placed. Where the bone was thin, less than 1.5 millimeters, you can see the marginal bone loss here. Okay, from the shoulder of the implant. So the bone has diminished, compared to where the bone is thick, no marginal bone loss, because there's still a vascularization that can take place even after the flap is opened. So this is avascular necrosis. And in a systematic review that was prepared for the most recent ITI consensus conference in Lisbon in April this year, the systematic review looking at clinical studies showed that if you have a thin bone wall, and they focused on the facial or buccal aspect, they are prone to exhibit major changes. And this can then compromise the integrity of that bone and can lead to both biologic and aesthetic complications. Okay, these are very strong statements now. If you lose bone through avascular necrosis, you risk aesthetics, but you also risk biological complications, because the implant surface is now exposed to the oral environment. And I can't show you the outcomes to the consent or the statements from the ITI consensus conference, because they're going to be published this month in the Clinical Oral Implants Research. So when it's published, it'll be out there, but because of copyright reasons, I cannot show you the statements yet. But what I can say is that the ITI recommends a minimum of 1.5 millimeters of facial bone. Personally, I would ask you to have 2 millimeters as a minimum, if you want to make sure you maintain the integrity of the facial bone. Is that easy to do? Because if you think about a standard implant, let's say 4 millimeters, and you want 1.5 millimeters on the lingual, 1.5 millimeters on the buccal, that's 3 millimeters plus 4, it's 7 millimeters. How many edentulous ridges are 7 millimeters in width? Yeah. If you go to the Mediterranean countries, Italian and Greek, yeah, I think you can find that. But if you go to the Asian communities, like Vietnam, Malaysia, you just don't have ridges like that because the bone phenotype is, and this is just the genetic phenotype of the patients. So then if you want 2 millimeters on the lingual, 2 millimeters on the buccal, and a standard implant, you have to have 8 millimeters. I mean, this is becoming very, very difficult to be able to respect those recommendations that the ITI is giving us. And of course, what do? As clinicians, we try our best. You know, okay, we'll try and squeeze an implant in, but you know what is going to happen. 5, 10 years down the track, these changes will take place. So we have to try everything we can to minimize that risk from happening. So this marginal bone loss, does it matter? Who cares? Look, this has been like this for 10 years. No problems. The bone is stable. Yeah, we've got some soft tissue recession, but does it really matter? In this patient, it doesn't matter. This patient, it matters. 1 year after placement. This is my patient. I treated this patient. I'll show you this case later when we talk about the treatment strategies. This is within 1 year of placement. Now we have exposed implants on a prosthesis that nobody can clean. I looked when she came back and I went, how do you clean this? So now this patient is in recall and maintenance very frequently to try and reduce the risk of developing peri-implantitis. So does it matter? Yes, it matters. It matters. Does it matter in this case? 2005 to 2022, for some reason I placed 3 implants side by side. Don't ask me what I was thinking about, but in 2005, this is what I did. 2 implants, 1 reduced diameter in the middle, and then splintered and a single. Sometimes you go back and look at your cases and go, what am I thinking? This should be a 3-unit bridge. Yeah, 3-unit bridge. Anyway, look at the middle implant. You can see the recession happening on the middle implant already. This one here, this middle implant. She's not the best toothbrusher in the world. Never had peri-implantitis, always a little bit of inflammation. 2015, 10 years, looks okay. Now we go to 13 years, bone loss. 13 years it starts. Now it's worse. Is it a problem? It is a problem, because we could go on to lose this implant. Right? So I stood up at the beginning and said, we have to have long-term success. And I asked you, how long is long-term? 5 years, 10 years? And this is my patient now, that not even 15 years in function, we're already seeing these changes. And the reason this has happened is because this implant went into a thin ridge with low soft tissue quality, and I put multiple implants. My decision, my mistake, which I do not see for 15 years before I start to see the effects of what I have done for this patient. So all of you out there, just remember this. Dental implants today never fail, very rarely fail. If you put an implant into the wrong position, guaranteed will never fail. If you have an implant you place and there's soft tissue recession, it's poor aesthetics, it will never fail. Right? This is the problem with implants today. They're so reliable. But all the other aspects to it are a real problem. And if you make these decisions and treat your patients for the next 10 years in the same way, then the next 10 years you're going to see all your complications. And because it takes so long to see a complication, we sometimes make the same mistakes over and over and over again. So with dental implantology, do not break the rules. Don't break the rules. Don't try and push to help your patient by squeezing an implant into a narrow bone. Think about the long-term consequences of what can happen here. So does it matter? Yes, it matters. Does it matter here? Does it matter here? Yes, it matters. Because this is what happens. In patients who are susceptible, they develop peri-implantitis, mucosal and marginal inflammation. So not all these implants are my cases. The one on the right side is mine. These are two that got referred to me to manage. But we all make these mistakes, and today I do not want to make these mistakes again. And because we now understand what can create these problems, we should be taking all steps necessary to reduce it. Okay, could you pass me the glass of water?
Yes.
I'm supposed to keep the water up here. So next thing I'd like to do is talk about overloading of implants. So when an implant is overloaded, there's two things can happen. Thank you. So when an implant is overloaded, oh, this is balancing. Ooh. I tell you what, put it down here. So when an implant is overloaded, two things can happen. You can either fracture the implant, or the implant can loosen in the bone. Today, the implants are so strong, especially in the Straumann range, with rock solid, almost never fracture these implants. Almost. They still can, but they're very, very strong. And the connection is so strong, rigid connection. In the days when we had external hex implants, the abutment can move on top of the implant. So what happens is the screw breaks, the abutment screw breaks. Now everything is so tight, nothing breaks. All the forces go into the bone. So I'm not going to talk about fractures. What I want to talk about is loss of integration, because I'm seeing this more and more and more. 10, 15 years that I'm starting to see these issues. And we now have a systematic review that absolutely confirms that if you have someone who is parafunctioning, who is a bruxer, then they're going to be at significantly higher risk of implant complication. We all knew this. Okay, we all knew this, but it's taken so long to actually get the high-level evidence to support this. It's a bit like saying, can parachutes save your life? And you want to do a randomized controlled study on someone with a parachute jumping out of the plane, someone without a parachute jumping out of the plane. And you want to prove that the parachutes can save a life. You know, we know inherently that bruxers are a problem. Parafunctioning is a problem. But now we have the evidence. So the definition is of overloading causing an implant failure is the loss of osseointegration in the absence of plaque-induced peri-implant inflammation. And if you compare 10 years between these two radiographs, so what do you see? You see a continuous radiolucency around the implant. And immediately next to the radiolucency, you see sclerotic bone changes. So the bone has been trying to adapt to the high forces and is becoming denser and denser. Sclerosis is happening. But it's reached a point where the bone can no longer repair itself, because remember, it creates microfractures, and then the bone has to repair. And it repairs by laying down more bone, corticalized bone, and that's why you see the sclerotic change. Eventually, it's overwhelmed and the implant becomes loose. And the first time your patient tells you this is painful to bite on. You know, sometimes it's not even loose yet, but it's painful to bite on. You take an X-ray, you see this. So the characteristics clinically is this mobility of the crown implant complex. And this is where I get the phone call from a patient. My receptionist comes to me and says, oh, Dr. Chen, your patient, Mrs. Smith, says her implant is loose. And then, of course, they fit the patient in. So in your head, you're thinking, just the crown. The crown is loose, it just needs to be tightened. Every once in a while, it's the whole implant that's loose. And that's when it's very, heartbreaking when you have to tell the patient that the implant has failed. There is no inflammation generally. This is not caused by inflammation. Normal probing pocket depths, normal marginal bone levels, but you see this continuous peri-implant radiolucency and the sclerotic changes in the bone. And then these are some examples. Okay, so it happens more and more frequently today. What's the problem? People, dentists place the implants, they put the prosthesis on, fit and forget. Fit the crown and forget it. Never check the occlusion again. And we all know occlusions change. They're dynamic, they're not static. It all changes. And because your implant has no proprioception, or much less proprioception, the patient's not going to tell you if they're overloading the implant. I don't know how many of you have patients who come and say, oh doctor, I'm biting too hard on this implant because I can sense the implant is under overload. Nobody tells you this, right? The first thing you see is the implant is loose. So you have to look for changes. I mean, look at this. These are splintered. This is a splintered prosthesis, and both implants are failing already. Okay, so we know from the Isidore studies, 1996, this is a monkey model. Unloaded on the left, excessive loads on the right. Two responses. An adaptive response, which means more bone gets laid down. And a non-adaptive response, which means completely breaks the integration. Right? And then you have this continuous radiolucency and mobility of the implant. So we've known about it for 30 years. But I don't know whether you remember the debate. Occlusal overload never happens. Never happens. Never happens. Doesn't exist. No such thing. It happens. Right? It happens, and it happens more often than we like. Now, lower molar implant I placed March 2013, restored, and this is 2 years later. The patient starts to get pain December 16, so this is more than 3 years, 3.5 years later. You can see the radiolucent line. So this case, carefully remove the crown without turning the implant, and then let the implant rest. If you turn the implant, when you put the closure screw in, you cannot get the crown back again. And if you're trying to wait for it to reintegrate, you turn the implant, the crown will also have to be turned. So be very careful if you do this. Sometimes I don't even put the closure screw on. If I can get the implant out, crown off, just leave the implant. Don't put anything in it, just leave it open. Because you do not want to turn the implant. And then you wait, give it time, unload it. The implant reintegrates. And it can be reintegrates again, right? It takes sometimes up to about a year if you're patient enough. And this only happens with SLA implants. I have never had this happen with any other implant service. No other implant service, right? And so we refitted the original crown, adjusted the occlusion, right? And make sure that that's checked on a regular basis, and give the patient an occlusal split, and get the dentist to check the occlusion at every appointment, every 6 months, and adjust the occlusion as necessary. Okay, so implants can reintegrate if you catch them in time and there's no rotational mobility. Sometimes the implant's just rocking, right? But then the trick is to be able to get the crown off without turning the implant, and not so easy. So what do you look for? This is a reduced diameter implant. It's a rock solid implant, and we have a really big crown. The restorative dentist. This is my case. I placed the implant, big crown. So this is now 6 months later, and then 1 year later, you can start to see this. I call it like a cupping effect. That cupping effect, this is like an angular change that takes place, and then you start to see the sclerotic changes. This is the warning sign now that this implant is under overload, and it will flex. So you have to intervene before you lose the implant. Yeah? So watch for that. So today, my protocols are, we check the occlusion regularly. If the patient's coming back to us, we will check the occlusion. Or I'll write to my referring dentist, say you must check the occlusion regularly and modify it. Posterior last standing teeth, like this here, tooth 47, I will place an implant with a regular neck. I don't put a wide neck in. Why? Because I force the prosthesis to become a smaller crown, not such a big crown. And look at the cusps, flat cusps, right? No cuspal inclines. Don't make these beautiful anatomic crowns with nice cuspal inclines. Just forget that, as flat as possible. And then the occlusion is checked on a regular basis. So everybody in our practice, including the hygienist, should stop articulating paper. And what we want is pull through in light centric, just hold in firm centric. Okay? I think we all understand that. For single teeth, more difficult for multiple missing teeth. Now the nice thing about overload is you can retrofit the whole crown. So you can put the crown back again if the crown didn't get thrown away. Sometimes they get thrown away. So here's a patient I haven't seen. This implant I placed in, I think, 10 years previously. So this is November 2019, upper canine implant. And you can see it's more. He's a film producer, very busy man, very important. Never comes back for checkups. All right, so there's the implant. Everything has come out. So I retain the crown. Straumann will provide a replacement implant for you under their warranty. So they just need to know why it is, but they replace it. Okay? And so here is after the implant came out. Here is 8 weeks later, like an early implant placement. So I then open up the site that's without preparation. No preparation was done. I can almost fit in, that was a 4.1 implant. Now I'm looking at a 4.8 regular neck implant. So I can place this implant with almost no preparation, of course, without the soft tissues. And then you can check the original crown. You can put the crown in, check the vertical displacement, check the rotation, and you can make these little adjustments. And also check that in centric, the implant is in the correct position. I actually put the implant a little deeper, right? So we want to create a bit more space on the implant. And so you can retrofit an implant like this. You can see this is a wide body implant with a regular neck. Isn't that nice? We have the same platform, but we can go to a wider implant. Now, a wider implant doesn't mean to say it cannot overload again, because everything is so stiff. And if the patient is boxing, they can loosen this implant again. So here's the retrofitted crown 1 year later. So original crown goes back in. Okay? So it's possible to do that on tissue level implants. You can also do this on bone level implants as well. I think I'm Melbourne's expert on retrofitting crowns, putting implants back and refitting the original crown. So you can do this with most implant and abutment connections. So this is a patient who the dentist rang me and said, oh, she's lost her implant, I pulled it out. This was the x-ray they sent us. Loss of integration around the neck of the implant. And then I went back to my original photographs 10 years previously, or 12 years previously, I think it was. This is the original surgery when the implant was placed into that central incisor site. So the implant was done as an early implant placement. Bone was intact. I did some GBR for contour augmentation. But the problem was the lack of bone support. The implant was always entirely within bone. Okay, so a re-entry is done, a minor re-preparation is done, and then the implant is placed. Now this was a complicated crown design. This was a customized abutment with a crown with a cross-pin retention. This was quite popular in Melbourne for more than 25 years. Everybody was doing these cross pins. Of course, today they abandoned them because they're difficult to do and they are more expensive. But because I have the abutment, the crown, abutment screw, and the cross pin, I can then check the fit directly in the mouth. So I can put the abutment back in, I check the timing, put the crown on. If it's still a bit turned, I turn the implant a bit more, and just very minor changes back and forth, and then you can retrofit the implant almost in the same position. And I do this by eye, estimating where the buccolingual position of the implant is. It's definitely worth a try, because it saves the patient the cost of the crown. And then I do some simple soft tissue, bone augmentation, just autogenous bone, was just grafted into the gap here. And I didn't use any more bone substitute. And the flap was closed, and this is the 2 years post-treatment retrofitting the original crown. So the bad thing about overload is that you can lose the implant. The good thing about overload is that the implant is lost without bone loss, just the integration. And you can sometimes retrofit, replace the implant and retrofit the old crown. Of course, I never promise this. You cannot promise that this will happen. Sometimes, especially in a molar site, we sometimes get some drifting, and you try and put the crown on, the contacts are too tight, and sometimes they have to strip back the porcelain. It's a PFM. PFMs are really nice because you can strip back the porcelain down to the abutment, and you can rebake or relaminate porcelain on top, and you can remake it with the crown. That way it saves the components. You cannot do this with zirconia crowns. If the zirconia crown doesn't fit, then you have to remake it. Okay. So let's go back to this patient that I started off with. And she is now in her 80s, as I mentioned to you, and everything is stable. So why was her treatment so successful? So sometimes psychologically we focus on our complications, and we forget that we also have many, many successes. And you sometimes need to go back and look at your successful cases to ask the question, why was this successful? What were the criteria, what were the clinical conditions to make this successful? So if I show you the original surgical photographs, so if you look at the image on the left, it's a bit out of focus. It's thick, soft tissues. Lots of keratinized tissue. Yes, there's been some resorption. Then you look at the bone. I mean, there's so much bone there that basically, as long as I center the implants nicely in the ridge, we have thick bone walls. So all the conditions are right for long-term stability. Thick, soft tissue, thick bone. And ladies and gentlemen, that's basically what implants need. This is what we've got to try and provide our patients. And as I mentioned, the challenge is when you have patients who don't have these kind of situations. The uneventful healing for this patient. So thin bone and thin soft tissues are the greatest risk for marginal bone loss, in my opinion. Right? Of course, we have the prosthetic design, we have the implant design, all those things that come with it. But from a biological point of view, these are the two key things. And now I say to your next patient that walks through your door, who's been missing all the lower molars for the last 5 years, and says, doctor, put some implants in. And even before you open their mouth, you know what you're going to find, right? You're going to find thin bone, and you're going to find minimal keratinized tissue over the ridge. So that's what happens. So then we have to think, all right, do we have to change our strategy for managing these patients? Or in fact, are these patients good candidates for implants? Because maybe not everybody should get an implant just because they have missing teeth, if the anatomical situation isn't favorable enough or you cannot change it. And then you increase that risk further. So if you have thin bone, thin soft tissues, then you have lack of keratinized tissue, and then you have muscle attachments. Okay, and when you put all this together, then there's a recipe for things to go wrong. The first thing I would say, if you have a case of thin soft tissues, and you still have the bone width that's favorable, then the implants should be placed a little deeper into the bone to compensate for some of that marginal bone recession. There's no science with this, okay? There's no science. This is purely from clinical, empirical experience. So with the tissue level implant, I always place the tissue level shoulder 0.5 millimeter into the bone, because we know from early radiographic studies you get that 0.5 millimeter bone loss. And with the bone level implants, I place 0.5 to 1 millimeter into the bone as well. Okay, so this just compensates to some extent for the marginal bone loss. And that's why I think from Straumann point of view, calling it a bone level implant is actually not the right thing, because we all think it must be at the bone level. But in fact, you should be putting it slightly under the bone level. All right, and then the bone remodels. You have your 2 millimeters of soft tissue, you then have the biologic width of 3 millimeters re-established. Okay, so that's the first thing. The second thing is we need to augment the bone. So where bone is missing, then I know we all want to try and save our patients some grafting procedures. We want to speed up their treatment. We want to reduce the cost of their treatment. But just pause each time you think about that, because the long-term consequences of placing an implant into a narrow ridge are significant, as I've shown you. So where it's necessary, we need to augment the bone. And we can do this in 3 ways. You can reduce the ridge height until the ridge gets wider. Okay, so ridge reduction. You can expand the ridge by using these ridge expansion techniques, or you can graft for lateral ridge augmentation. So I don't do any ridge expansion techniques. I've tried them and I don't like them, and I'm not, in my hands they don't really work, so I won't talk about that. So the 2 that I principally employ therefore are a ridge reduction, when I know I can reduce the ridge to get the width, or we do our grafting procedures to increase the bone thickness. Now remember, I said to you at the start that we want to provide predictable treatment with minimal risk to the patient. So sometimes to get predictable treatment, you have to do more treatment. Right? Predictable treatment doesn't mean less treatment. So sometimes more treatment is required to be able to get that predictability in the long term. Okay, so let's look at the first one, flattening the ridge. So when the ridge is narrow and tapered, if you're able to reduce the ridge height by 1 to 2 millimeters, you can broaden the ridge, and then that allows you to place the implants depending upon the diameter you select to maintain that minimum 1.5 to 2 millimeters of facial and lingual bone. So that's the ideal situation that we want. So the advantage is that, yes, it broadens the ridge. It also shifts the center of the ridge to the buccal side. So wherever there's the resorption, usually from the buccal, you have a ridge. You have a ridge that's centered here. As you flatten the ridge, the center of the ridge moves to the buccal side. And that means you can correct the position of the implant and avoid being implant too lingual. Yeah, to a certain extent. You can't do that completely, but to a certain extent, you can do that. And where it's necessary, you increase the prosthetic space. So these are the advantages of ridge reduction. The disadvantage is ridge reduction. It reduces available bone height. And if you already have reduced height, if you're tight for height because of anatomical structures, then this becomes a problem. And if you have to do a lot of reduction, you lose the cortical bone at the crest, which can then have an impact upon the primary stability of the implant. So it's this very fine balancing act. Now today, with CBCT and computer-guided and digital planning, we can predict ahead of time how much ridge reduction is necessary, how much residual bone height there is, can we correct the axis of the implant. So all these things can be done before you even open up a flap. In the old days, you had to make that decision intraoperatively, which was not the best way of doing it. So today, I urge all of you to take advantage of the digital technology, use co-diagnostics or any other image software package, and see how the implant can be placed and whether there are any other options to choose. And then with lateral ridge augmentation. This is a typical lower molar, would you agree? Long-standing. I do more single tooth grafts for single lower molars than any other type of graft, because the patient is missing a tooth for a long period of time. And today I use a relatively simple technique. We harvest from the retromolar area, the external oblique ridge, using a Trifine. So you can see the narrow ridge, you can see the flap is open. I've decorticated the surface, right? We made our little opening. And then this is not the same case, this is from one of my students. We photographed it. So we use a Trifine burr, right, to harvest a small cortical block. In the same area, you know, you open up the flap, take a little block. It's technically a bit sensitive, but it's not impossible to learn how to do, and it's relatively simple. And I pre-make the central hole before I use the trephine. I just make the mark with the trephine, then I make the central hole, then I finish with the trephine, and we take the block out. And then that's pinned into position on the buccal aspect. And then all the gaps around it are surrounded by biomaterial. This is DBBM in a collagen matrix, and then protected by a membrane. Now we know from the research, the combination of cortical cancellous block, together with DBBM under a membrane, people can get almost no graft resorption. Right? We know this is well established now. Okay, so this is now the 6 months post-treatment. You can see we've increased the ridge of the width. You can see the graft in position. Now the implant osteotomy can be created, the implant's in a good position. And now we have good contour of the crown, not only in good bone, but the implant is centrally in the mesiodistal space. It's not towards the lingual side. So today, this is actually the most common bone graft I do in my office today, these grafts, because it is such a common problem to have the buccal resorption in a long-standing edentulous lower molar site, single tooth site in particular. Here's just a case that was finished recently, just another example, right? So this patient required a sinus ball graft in the second premolar site, and was lacking bone width in the canine site because of long-standing missing tooth, wearing a partial denture for a long period of time. This patient is from Taiwan, and a lot of this dental work was done there before he eventually migrated to Australia. So that premolar tooth was lost, as you can see in the middle image, the healing site. And so I've done a lateral window sinus graft. I don't have a photo of the lateral window, it's further back, but I've taken the bone out that I used for the lateral window, and I've used it here. So that's the bone from the lateral window in a sandwich technique. So underneath that is DBBM. Okay, using a lag screw, we just create the space. It's like a shell technique. It's a modification of the shell technique. So the lateral window is done, and all done in the same site. So the donor bone comes from the same site. So this is, I try to do these procedures to try and minimize the invasiveness for my patient. Okay, so 6 months of healing, the re-entry, and that allows the implants to be placed in a nice position. This was done with guided surgery, by the way. So the implants were correctly positioned, maintaining the good bone wall. So you can see sinus ball graft on the distal side, and then the lateral augmentation on the canine side. So another case of more treatment is required to make the underlying conditions favorable for long-term success. Of course, this is only 1 year, so I can't tell you if this is long-term success yet, but we monitor the patient, and the prosthesis is cleanable. Although there's a flange has been added to it, it's cleanable. Oh, and by the way, you can see the implants are placed under the bone level. Yeah, so exactly what I mentioned to you, and you see no marginal bone loss around the next of the implant. Okay, I want to show you this case. This is a case that I treated, and all of us have done this at some stage. We place an implant and we go, oh, it's a bit narrow. There's a bit of a dehiscence in the heel side. I'm just going to put some biomaterial or some autogenous bone chips, and I'll close up. Right? So we all think that we can graft it that way. This case, I can tell you, I treated, and I don't know why I didn't end up doing a graft and why I decided to go ahead. But again, this was a clinical decision I made, and a mistake and an error that I made. But I show this to you because it demonstrates clearly why GBR in no-wall defects does not work. It does not work. So you focus on this the posterior implant. You see the implant's in a heel site. This is called a no-wall defect. The implant is outside the bony envelope. Okay, so what did I do? I perforated the cortical bone. I take autogenous bone scrapings off the buccal side. I mixed it with deproteinized bovine bone mineral, everything that you're supposed to do, right? Reconstituted in venous blood, and then laid in there, and then a membrane over the top, and primary closure. Technically, everything's fine. But then at re-entry, zero bone regeneration. zero bone regeneration, because this is not a contained defect. And GBR only works when you have bone walls for the progenitor cells to grow from. Bone cells will not grow out this way and that way. They cannot do that. They do not have the capacity to do that. Right? And so we're asking too much of the GBR technique. The technique was performed technically well. I was happy with the technique, but I'm asking too much of Mother Nature and the cells to do this. Okay, so that's the start, and that's the treatment. I may as well have not bothered. So if you see cases like this and you think, I'm just going to put a bit of bone scraping, I put a little bit of iron material, a bit of DBBN, bovine bone mineral, allograft, close it up, that's fine. Because if you never do a re-entry, you will never see it doesn't work. And then what happens, of course, you set up the conditions for bone loss. This was the case I showed you earlier. Avascular necrosis has taken place. I'm not proud of this case, but I'm happy to share it to you because this is a really big learning exercise for me. So that was the bone. What about the soft tissues? Because I think this is quite a popular topic now with grafting and so on. And although I'm a periodontist, I have to be honest to say in the past I've probably not spent enough time thinking about the soft tissue requirements for long-term success. I've tended to treat this after the complication has arisen, rather than trying to preemptively manage it. So we've got 3 time frames that we can do our soft tissue grafting. It can be before implant placement, it can be at the time of implant placement, and it can be after implant placement. And after implant placement, of course, is you're dealing with the complication already. Okay? At the time, and pre means you recognize that there's lack of, of soft tissue volume. All right, so here's a case of a patient requiring some soft tissue to graft. So the patient was referred to me after the teeth had been extracted and the flap coronally advanced. Okay, so you've all seen this before. The flap has been coronally advanced to get soft tissue closure, and you see here is the keratinized tissue. All that is movable mucosa. Of course, you can make a paramedian incision and try and rotate it and move it with the flap to the buccal side, but I felt this was too much. Too much movement, so I just did a small strip free gingival graft. Very simple to do. The donor site is from the same area, and we just grafted it to the buccal. So this is kind of bread and butter for periodontists, providing a zone of keratinized tissue. And now we have a nice ridge. Now we can place the implant and have a good zone of thick keratinized tissue around the implant. Okay, so this is preemptively doing the grafting procedure. This case needs a bone graft. Okay, you can see from the CBCT, this is not my plan, this was sent to me like this, but clearly you can see the ridge is not wide enough and the patient will need a bone graft. But when you look at the clinical situation, you can see the problem with the lack of tissue. All right, you can see also the lack of quality of the tissue on that molar tooth. Right, so the plan here was to improve the quality of the tissue before doing the bone graft, which would then assist in being able to raise a flap for both the graft as well as subsequently for the implant placement. Okay, so again, another strip graft from the palate, a free gingival graft, and you can see how it's basically a split thickness flap, and I wrapped it not only in the crestal region here, but it came around also onto the buccal side of the lower molar to increase the thickness, because the flap's going to go up there. You're going to be raising the flap, which will involve that tooth. Right, so that's the pre and the post. So now we have tissue to work with. And so now the flap is raised, grafting is done as I showed you previously, and we've improved the bone conditions, but prior to that, obviously, we've improved the soft tissue conditions as well. So soft tissues improve, bones improve, and now everything is fine for the subsequent placement of the dental implant. All right, so here's soft tissue grafting after. So this was referred to me, please graft, because now we have a situation of bone loss, we have a situation of marginal inflammation, periimplantitis, lack of keratinized tissue, and this patient is actually very uncomfortable. Okay, so here I do a large connective tissue graft onto which a zone of keratinized tissue is retained, and then we wrap this around the implant, as you can see here. All right, you can see now on the right-hand side, this creates a zone of keratinized tissue which is bound down. It's still a problem because there's still bone loss, still needs to be maintained, but the patient at least is now a bit more comfortable. This is what I call the rescue treatments for implants. Better this was corrected at the beginning and not after the event. And just some other examples. Yeah, we've got a fenestration here. So we have a soft tissue fenestration, exposed, the implant can be probed through. We know that in time, what will happen is that will end up receding. So a small split thickness flap is created, connective tissue graft, and we can thicken the soft tissue, thicken the zone of keratinized mucosa, and repair the fenestration at the same time. Okay, so this soft tissue procedure is actually very, very useful. But as I said before, it's better if you can treat it prior to or at the time that the implant's placed, rather than as an afterthought. So I looked at bone, I looked at soft tissue. Now we will finish up specifically looking at post-extraction. So remember the post-extraction resorption that takes place. So today we have the techniques of grafting of the socket grafting to assist us if we need to maintain the volume of bone for an implant. So in post-extraction sites, there are three things that you can do. Well, 2 things you can do and 1 thing you don't do. The first is do nothing. Take the tooth out, let nature do what will happen with the healing, place the implant, and whatever happens, happens. The ongoing one, okay? Just don't care, doesn't matter. And of course that's quite a valid way of doing this. I mean, this is what we've been doing for years and years before we really understood. We can reconstruct this with guided bone regeneration, with early implant placement. And I'll talk more about this after the coffee break. Or we can try and prevent this from happening with the socket grafting. Now we know that socket grafting does not stop the resorption, but it minimizes the resorption to the point where you can still place implants. Okay, so this is doing nothing. All my cases, all 10 years. Anterior, premolar, posterior sites. So if you do nothing in a post-extraction site, you can expect these ongoing changes to take place. All implants healthy, all bone levels are healthy. We just have now ridge depressions and concavities, which in the case of the molar is causing food retention, which is a concern to the patients. But there's nothing wrong with the actual implant itself. It is very annoying to get food retaining in this area all the time. So this is the option of doing nothing. So when you take out the tooth and place the implant, this is the reconstruct the ridge. Do something to build the bone up. And here you can see an implant place. The buccal bone is a little bit on the thin side. You can probably see, I don't know whether you can see this, the perforations of the buccal plate to open up the trabecular space. And then biomaterial, this is deproteinized bovine bone mineral in a collagen matrix, so it handles very well. You sit it there, close it up, and 4 months later the CBCT shows that reconstructed buccal bone. No membrane used. So I don't use membranes with this because I'm just trying to thicken the bone, thicken the soft tissue, reconstruct the shape of the ridge so that we don't get that depression. And the implant itself is in original bone. So I don't need the membrane to try and get maximum bone regeneration. Even if it partially regenerates, it's sufficient. In this case, it was actually quite a lot of regeneration. So this case of a failed 4-unit bridge in the mandible, and when the bridge comes off, you can see the pontic area. So you know this person resolves. The bone is relatively thin to begin with, And you know, if you take these teeth out and you wait 8-10 weeks, everything's going to resolve because this is a thin bone phenotype case. By the way, this patient is 6 feet 4 inches tall, big guy, but he's got very fine bone in his jaws. It's really weird. It's so strange. So anyway, the treatment for this patient was to say, okay, we take out this teeth, we're going to graft the extraction sockets to minimize the post-extraction resorption. So this is, I used DBBM in this case. This is just particulate DBBM in the socket, and just seal it with a gelatin sponge. Okay, and this is, we wait 3 months. And then the re-entry shows we have maintained the ridges in those 2 areas, enough to allow the implants to be placed. Okay, so this overcomes so many headaches for a patient. A simple procedure you can do at the time of extraction can then make your life much easier later on when you come to place the implant. With some of the materials, you can go back in at 2 months to place the implant. I recommend you wait 3-4 months. Don't rush it. Take your time because the bone is better quality the longer you leave it. It's a completely different situation in the anterior region, maxillary anterior region. So after the coffee break, I have a study to share with you that shows the dimensional changes if you are grafting in the aesthetic area and where maybe additional grafting is needed. Okay, so these implants placed, this is the 4-year outcome. Okay, so I'll conclude this first session in the morning by saying the following. So for long-term functional success, aesthetics is later, yeah? So for long-term functional success, we need to respect the soft tissue and the bone requirements. And the bone and the soft tissue work together. There is an intimate relationship between the two, and you cannot separate them. You have to think about both bone and soft tissue at the same time. Implants need to be placed with a minimum, now this is in healed sites, yeah, in healed sites, minimum of 1.5 millimeters of buccal and lingual bone thickness. And if there is not enough bone width and you cannot get that bone width by ridge reduction, then staged bone grafting is recommended. And GBR should only be done when you have residual bone walls. And again, I'll go through the bone walls in the session after the coffee break. Okay. Implants need to have a minimum of 2 to 3 millimeters of keratinized mucosa, both on the buccal and on the oral, buccal and lingual sides, to maintain soft tissue health and marginal bone. Okay, that's a really important requirement. And soft tissue grafting, today you even have soft tissue substitutes that you could use if you don't have enough soft tissue to harvest from the palate, okay? So, better to think about the requirements and manage them as part of the treatment rather than try and do this afterwards to deal with the complication. So, you know the old saying is if something happens and then you have to treat it later, it's a complication, and then you're giving an excuse or a reason. But if you talk to your patients beforehand and you preempt things and say, this is what could happen, this is what we need to do. If your patient says, no, I don't want the grafting, I don't want this, I don't want that, well, that's fine. And that's their decision. Right? But it's no longer an excuse if something happens down the track because you thought about it. Okay, so thank you very much. I don't know whether we have time for the questions right now. I'm not sure what we're doing, or we go straight to coffee break.